Alright, in this chapter we'll be talking about environmental emergency. There's your competencies for trauma. We'll be recognizing the recognition of management of submersion instances and temperature-related instances. Patho assessment and management of near drowning, temperature-related illness, and bites and venomation. Also, some dysbaryism, which are high altitude and diving injuries, electrical injuries, and radiation exposure. Medical conditions caused by exacerbated by weather, terrain, and atmospheric pressure is your environmental emergencies. A variety of medical emergencies can result, in particularly to children, older people with chronic illnesses, young adults who overexert themselves. The environmental effect on mobility and mortality increases with stressors that induce and exacerbate other medical traumatic conditions. Factors affecting exposures, thermoregulation is the balance between heat production and heat excretion. So the rise in the core body temperature elicits responses that increase heat loss and shut off normal heat production pathways, aka thermogenesis. Decreases in core body temperature promotes heat production and conservation and turns off normal heat liberating pathways, thermolysis. Factors affecting heat exposure can include the physical condition of the patient, age of the patient, nutrition and hydration of the patient, and environmental conditions in broad. So with cold exposures, your normal body temperature must be maintained within a narrow range for the body's chemistry to work efficiently. Hypothermia is a core body temperature falls because of inadequate internal heat production, such as thermogenesis, excess cold stress, or a combination of both. The body can lose heat through conduction, convection, evaporation, radiation, and respiration. The rate and amount of heat loss or gain by the body can be modified in three ways: an increase or decrease in heat production. You can move to an area in which heat loss is decreased or increased, or you can be wearing appropriate clothing for the environment. This figure shows a wind chill factor table from the National Weather Service. And this figure shows you a heat index. So hypothermia occurs when body temperature falls below 95 degrees Fahrenheit. The body can regulate its temperature and generate body heat. Many body functions begin to slow down as cold exposure continues. It can develop quickly or gradually. Temperature does not have to be below freezing for hypothermia to occur, more common among geriatric, pediatric, and ill patients. Alcohol is a common contributor to hypothermia. Impaired thermoregulation can occur when therapeutic use or overdoses of sedative medication. Some signs and symptoms increases in severity as cold temperature falls. Generally progresses through 4 stages. You assess the temperature of the patient's skin close to their trunk or core. Now on the outside that's been exposed, you always want to assess towards the core. Rectal temperature is considered the most accurate for assessment of hypothermia. Mild hypothermia is a core temperature between 95 and 93. Moderate hypothermia is a core temperature is 92 to 89. So as your core temperature begins to fall below 85 degrees Fahrenheit, the patient becomes lethargic. The cold temperature continues to fall below 80 degrees Fahrenheit, vital signs begin to flood. At a core temperature of 80 degrees Fahrenheit, all cardiorespiratory activity may cease. Never assume that a cold patient is pulseless and dead. Patients are not dead until they're warm and dead. Localized cold injuries to exposed body parts of the body. Frostnip, chilblains, or emerging fluid can result when exposed parts of the body become very cold but not frozen. In systemic hypothermia, blood is shunted away from the extremities to maintain core temperature. Both local and systemic cold exposure injuries can occur in the same patient. Frostnip and emerging fluid. Frostnip often affects the ears, nose, and fingers and is not painful. Emerging fluid occurs after prolonged exposure to the cold water. The skin is pale or blanched and cold to the touch. Frostbite, the tissues are frozen, permanently damaged cells. If gangrene occurs, the dead tissue must be surgically removed and identified by the hard waxy color of the affected tissue. As with a burn, depth of the skin damage will vary. Assessment of cold injuries management includes stabilizing ABCs and preventing further heat loss. All patients who are injured are at risk for hypothermia. So always, you're staying size up, look for your air temperature, your wind chill, and whether it's wet or dry outside. Ensure that the scene is safe. Identify any safety hazards such as wet grass, mud, snow, or icy streets. Consider special hazards such as avalanches. Cold environments may present special problems. Use appropriate standard precautions. Consider your number of patients and some additional help as quickly as possible. And always look for your mechanism of injury. In your primary survey, form a general impression. Chief complaint may be only that he or she is cold, but it may be complicated as existing medical problems or trauma. Perform a rapid full-body scan to determine whether a life threat exists. If chief complaint is simply being cold, quickly assess core temperature. Evaluate the patient's mental status using AFPU, and all the mental status can be affected by the intensity of the cold injury. Take into account the physiological changes that occur as a result of hypothermia. Airway breathing. If you believe the patient is cardiac arrest, provide high-quality chest compression. If you cannot find a radial pulse, gently palpate for a carotid pulse and wait for up to 60 seconds before you decide that the patient is pulsed. Some recommend that CPR can be delayed before you decide. Some recommend that CPR be delayed or suspended until in severe hypothermia. Ensure that the patient has adequate airway and is breathing. The patient's breathing is slow or shallow. Ventilation with a background device may be necessary. If available, warm humidified oxygen helps to warm the patient from the inside out. Even mild hypothermia can have a serious consequence and complications. All patients with hypothermia require immediate transport for evaluation and treatment. Assess for the safest way to quickly move your patient from the cold environment. General transportation is necessary, and transport the patient with the head level slightly down. In your history taking, investigate the chief complaint, obtain a medical history, be alert for specific signs and symptoms, and always try to determine duration of the exposure, temperature to which the body part was exposed, and wind velocity. Get your sample, especially light oil intake, and the activity prior to the exposure. Investigate underlying factors such as exposure to wet conditions, inadequate insulation from cold or wind, and restricted circulation from tight clothing or shoes, and assess your circulatory diseases. Look for fatigue, inadequate nutrition, alcohol and drug abuse, diabetes, cardiovascular age, and disease. In your secondary assessment, focus on the physical exam, the severity of the hypothermia, determine the degree and extent of the cold injury. Special attention to skin temperatures, textures, and turgor is crucial. Vital signs may be altered by the effects of hypothermia. Respirations may be slow and shallow. Low blood pressure and slow pulse. indicate moderate to severe hypothermia. Determine the core body temperature using a hypothermia thermometer based on your local protocol. Pulse oximetry will often be inadequate or inaccurate because of the lack of perfusion in the instrument. In your reassessment, look at your vital signs and check complaint, review all your treatment, monitor the level of consciousness and vital signs, and communicate all information gathered through receiving. Always try to remove your clothing and keep the patient dry. Prevent conduction heat loss. And remove the patient from the cold environment. To prevent further damage to the feet, do not allow the patient alone. Remove any wet or frozen clothing and place dry blankets over and under the patient. So if available, give warm humidified oxygen, obtain IV access, but follow local protocols for administering fluid to a patient with hypothermia. So when possible, administer fluid that has been warmed. Handle the patient gently to avoid pain and further injury to the skin. So do not massage the extremities or allow the patient to eat or use any kind of stimulant. In mild hypothermia, signs and symptoms include alertness, shivering, responding appropriately, core body temperature between 90 and 95 degrees. So begin passive rewarming slowly, turn the heat up, rewarm the patient slowly, and if possible, give warm fluids by moderate to severe hypothermia. Active rewarming is best accomplished in the ED. Rewarming the extremities too rapidly without rewarming the core can cause vasodilation. Local protocols may dictate the appropriate type of rewarming strategy. If you cannot get the patient out of the cold immediately, move the patient out of the wind and away from contact with any object that will conduct heat away from the body. Withholding and cessation of resuscitative efforts. Exturbation preceded the arrest. Successful resuscitation is unlikely. Trauma, alcohol overdose, and drug overdose could have resulted in hypothermia. Effects of hypothermia may protect the brain and organs if hypothermia develops quickly. Fixed dilated pupils, apparent rigor mortis, and dependent lability are not contraindications for resuscitation in severely hypothermic patients. So in your emergency treatment, remove the patient from further exposure to the cold and handle the injured part gently and protect it from further injury. Administer O2, remove any wet or restricting clothing over the injured part. If there's no chance of re-injury to a more superficial local cold injury, consider active rewarming. With frost nip, contact with a warm object may be all that is needed. With emergency grip, remove wet shoes, boots, and socks. Split the extremity, cover it loosely with a dry, sterile dressing. Never rub injured tissue, and do not re-expose the injury to cold. With a late or deep cold injury, be sure to remove any jewelry or other potentially restrictive items from the injured part. Cover injury loosely with a dry, sterile dressing. Do not break blisters or rub or massage the area. Do not apply heat or rewarm the part. And do not allow a patient to stand or walk on frostbitten fluid. Evaluate for signs and symptoms of systemic hypothermia and support vital functions and transport properly. Rewarming in the field, use a warm water bath. So if prompt hospital care is not available, or medical control instructs you to institute rewarming in the field, use a warm water bath. Immerse your frostbitten part in water with a temperature between 100 degrees to 105 degrees Fahrenheit. Recheck your temperature frequently. Water temperature should never exceed 105. Store the water constantly. Keep phosphorescent part in the water until it feels warm and sensation has returned to the skin. Dress the area with a dry, sterile dressing and expect the patient to report severe pain. Consider administration of nitrous oxide or call a paramedic backup to administer analgesia. Never intently warming if there is any chance that the part may freeze again before the patient reaches the hospital. Cover frostbitten part with soft, padded, sterile cotton dressing. If blisters have formed, do not break. Cold exposure in you. You are also at risk for hypothermia if you work in a cold environment. Cold weather search and rescue operations are a possibility in your area. You need survival training to precautionary tips. Be thoroughly familiar with local conditions. Be aware of existing and potential weather conditions. Wear proper clothing whenever appropriate, and properly maintain and equip the vehicle. Heat exposure. Your normal body temperature is 98.6 degrees Fahrenheit. When the body produces excess heat, it will try to rid itself of excess heat through thermolysis. The two most efficient methods to decrease heat are sweating and dilation of peripheral blood vessels. When the body is exposed to or generates more heat energy than it can lose, hypothermia can result. Hypothermia is a high core temperature, usually 101 degrees Fahrenheit. So when the body is making energies to decrease body heat or overwhelm, illness develops. High air temperatures can reduce the body's ability to lose heat by radiation. High humidity reduces the ability to lose heat through evaporation. Vigorous exercise causes loss of fluid and electrolytes. Heat exposure can cause heat cramps, heat exhaustion, heat stroke, and all three may be present at the same time. Heat exhaustion may progress to heat stroke. Persons at greatest risk for heat illnesses are children, geriatric patients, and your patients with heart disease, COPD, diabetes, dehydration, and obesity. Patients with limited mobility and alcohol and certain drugs may also make a person more susceptible. Preventative measures. Maintain adequate fluid intake. Acclimatize to the environment itself. Limit your exposure. And drink water continually. People working outside high temperatures should drink water continually to replace what is lost through perspiration. Heat cramps or painful muscle spasms occurring after vigorous exercise. Dehydration may have a role, and it usually occurs in the legs or abdominal muscles. Heat exhaustion, also called heat prostration or heat collapse, is most commonly serious illness caused by heat, or results from body losing so much water and electrolytes that the very heavy sweating that hypovolemia occurs. Signs and symptoms include onset while working vigorously or exercising in a hot, humid, or poorly ventilated environment and sweating heavily. Onset is even at rest in the older and infant age groups in hot, humid, and poorly ventilated environments. Cold claim of skin and dry tongue and thirst. Dizziness, weakness, faintness with accompanying nausea or headache. Normal vital signs, normal or slightly elevated body temperature. It may be a subtle increase in core body temperature with some neurological deficit. Symptoms may be solely a result of dehydration combined with overexertion. Symptoms that do not resolve with rest and positioning may be a result of increased body core temperature. Heat stroke is the most serious injury caused by heat exposure. It occurs when the body is subjected to more heat than can effectively remove. Body temperature rises rapidly to a level at which tissues are destroyed. It can develop in patients during vigorous physical activity or when they are outdoors in a closed, poorly ventilated human space. Hot, dry, flushed skin. And do not rule out heat stroke even if the patient's skin is moist. A patient can have a heat stroke even if he or she is still sweating. The first sign is a change in behavior, and the telltale sign the patient no longer perspiring. Classic heat stroke commonly presents when people with chronic illnesses. Exertional heat stroke commonly presents in people who are in good general health but have an increased core body temperature because of overwhelming heat stress. Recovery from heat stroke depends on the speed with which temperature is administered. And you're seeing size up, do your environmental assessment, look for hazards and clues, use appropriate standard precautions. Heat emergencies commonly occur during athletic events and practices. And overcooling can result in shivering, which generates more. In your primary survey, observe the patient and how they interact with you and the environment. Perform a rapid full body scan. Assess your altitude skill for your mental status. Do your airway and breathing. Consider spinal precautions if trauma is a possibility. And assess circulation. Treat aggressively for shock. And for signs of heat stroke, transport without delay to an appropriate facility. When your history is taken, get your medical history. Get your sample. Be thorough as far as exposure and how long they were exposed to the area. And see if you can determine what the heat was and possible humidity. If the patient is alert, perform your focused assessment. If your patient is unresponsive, perform physical examination of the whole body. Assess for muscle cramps and confusion. Examine the patient's mental status and obtain vital signs. Perform neurological examination. Patients with hypothermia will be tachycardic and tachypnea. And check your patient's temperature. In your reassessment, watch these patients for deterioration very quickly. Get your vital signs every 5 minutes. Evaluate the effectiveness of your interventions. And be careful not to cause shivering when cooling down a patient. Also, document weather conditions and activities the patient was performing prior to an emergency in your patient care. Alright, for heat cramps, remove the patient from the hot environment, high flow 2, rest the muscle cramping, fluids by mouth, and cool the patient with a water spray or mist, and add convection by manually or mechanically fanning the patient. When the heat cramps are gone, the patient may resume activity, so heavy sweating can cause muscle cramps to recur. The best preventative and treatment strategy is hydration by drinking water. If the cramps do not go away after these measures, initiate IV line and transport to the appropriate facility. If you're uncertain that the cramps are caused by heat or you know anything out of the ordinary, contact medical control or transport to the hospital. In exhaustion, treatment is aimed at removing the patient from the exposure, and if an ice bath or similar facility is available, provide cold water immersion to the patient if allowed. Prepare to transport the patient if symptoms do not promptly clear up, level of consciousness decreases, and body temperature remains elevated. So a person is very young, older, or has an underlying medical condition. Alright, drowning, respiratory impairment from submersion or immersion in liquid. Patients with submersion injury can die of secondary complications that occur beyond 24 hours. Inhaling very small amounts of fresh or salt water can severely irritate the larynx, resulting in laryngeal spasms. A laryngeal spasm prevents more water from entering the lungs. Hypothermia is a major consideration. The body's diving reflex may actually slow, and metabolism to the point of protecting vital organs. Hypoxia is always the first concern. In diving emergencies, most serious water-related injuries associated with dives, with or without a scuba gear. Some problems are related to the nature of the dive, and others result from panic. Physical principles of pressure effects. Pressure may be expressed in several ways. Measurement in ATA is commonly used in diving medicine. So most scuba diving is done in depths between 30 to 60. So liquids such as water are not compressible. Gases are compressible and follow physical laws. Boyle's laws is at constant temperature, the volume of a gas is inversely proportional to its pressure. Dalton's law, each gaseous mixture exerts the same partial pressure that it would exert if it were alone in the same volume. In Henry's law, the amount of gas dissolved in a liquid is directly proportional to the partial pressure of the gas above the liquid. This law explains the compression sickness or the bends. Per Boyle's law, the volume of nitrogen decreases as pressure increases. Per Henry's law, as pressure decreases during ascent, nitrogen comes out of solution in the blood. Dive tables and dive computer provides guidelines for divers regarding when to take decompression stops during the dive. So, your diving history. Obtain as many details as you can about the dive and the onset of the patient's symptoms. Use a special form that records the following information. When did the symptoms start? What type of dive was done and what type of equipment was used? What type of tank was used? Where is the diving site and what's the water temperature? How many dives were made within the past 72 hours? At what depth, bottom time, and surface interval for each? Was the dive computer used? Were safety stops used? And were there any attempts in water decompression? Were there any dive complications? And what were the pre-dive and post-dive activities? Descent emergency. Major problem during descent is barotrauma. Barotrauma can result from compression of gases within the body spaces during descent or expansion of gases within those spaces during the ascent. So as long as the air-filled cavities of the body can equilibrate freely, they will not implode. A person with a perforated lymphatic membrane may develop a special problem while diving. Injuries at depth. Nitrogen narcosis is a state of autoimmune status caused by breathing compressed nitrogen-containing air at the depth. Ascent emergency. Most of the serious injuries associated with diving are related to ascending from the bottom. Usually requires aggressive resuscitation. Two particularly dangerous medical emergencies are air embolism and decompression sickness. Pulmonary overpressurization syndrome, or the POP, can occur when a diver fails to exhale during an ascent. It can result in cause a pneumothorax, mediastinal and subcutaneous emphysema, alveolar hemorrhage, and lethal air embolism. People with COPD and asthma are at slightly increased risk. Signs and symptoms depend partly on where the escaping air ends up. A physical examination may reveal palatable subcutaneous air above the clavicles. Always look for unequal breath sounds, low pulse oximetry values, and hyperrenaissance on the affected side of the chest. An air embolism is bubbles of air in the blood vessels. Air pressure in the lung remains at a high level, while the external pressure on the chest decreases. Air inside the lungs expands rapidly. The air released from the rupture can enter the pleural space, the mediastinum, and the bloodstream. A pneumothorax and pneumomediastinum both can result in pain and severe dizziness. Potential signs and symptoms of air embolism are blotching, froth at the nose and mouth, severe pain in muscle joints and abdomen, dizziness, localized pleuritic chest pain, dizziness, nausea, vomiting, dysphagia, and a cough. Also, irregular pulse or even cardiac arrest. Decompression sickness is bubbles of gas obstructing the blood vessel. Results from too rapid of an ascent from a dive, too long of a dive, or too deep of a dive, or repeated dives within a short period. Most triggering symptoms are abdominal and/or joint pain. Correction, most striking symptoms are abdominal and/or joint pain. Dive tables and small diving computers are available to calculate and record the proper rate of ascent from a dive. A sudden decrease in external pressure from the body and release of dissolved nitrogen from the blood forms bubbles of nitrogen gas within the blood vessel. Difficult to distinguish between air embolism and decompression sickness. Air embolism occurs immediately on return to the surface. Symptoms of decompression sickness may not occur for several hours. Treatment consists of oxygen administration, monitoring, transport, followed by recompression of the hyperbaric chamber. Recompression treatment allows the bubbles of gas to dissolve into the blood and equalizes pressures inside and outside the lungs. Alright, water rescue. Rescue and removal of patient matters first. The basic rules of water rescue are: first, try to reach the patient, then throw a patient a rope, life preserver, or any floatable object that is available. Next, use a boat if one is available, and do not attempt swimming unless you are properly trained. Be prepared for rapid hypothermia in cold environments. For colder areas, a plan for ice rescue is necessary. Success depends on how rapidly the patient is removed from the water and ventilation. Spinal injuries and submersion incidents. It can be complicated by spinal injuries and spinal cord injuries. Assume a spinal cord injury exists when submersion has resulted from a diving mishap or a fall from substantial height. If the patient is unresponsive, no information is available to rule out a neck injury, and the patient is responsive but reports weakness, paralysis, numbness, or tingling in the arms or legs. Recovery techniques is an organized rescue effort calls for providers who are experienced with recovery techniques, equipment, including snorkel, mask, and scuba gear. Alright, things size up, safety, check for your hazards, PPT, use extreme caution driving through standing water. Never try to water rescue without proper training and equipment. So always call for additional resources early. Get your general impression, assess for life threat, determine the level of spinal stabilization is necessary. Pay attention to the chest pain, dyspnea, complaints of sensory changes when a diving emergency is suspected. Get your aptitude scale and be suspicious of alcohol use in it. Open the airway in unresponsive patients. Always take consideration of spinal trauma. Searching if the patient has vomiting or if pink frothy secretions are found in the airway. Provide ventilation with a bag mask device and inadequate breathing. The patient is responsive, provide high flow oxygen with a non-rebreather mask, and if there's no risk of spinal injury, position the patient to protect the airway from aspiration in the event of vomiting. And always monitor your breath. Check for pulse and circulation. Never give up on resuscitation. A cold water drowning victim. Exposure to cold water will occasionally activate certain primitive reflexes. Evaluate for adequate perfusion. And if the mechanism of injury suggests trauma, assess for bleeding and treat a person. Transport decision. Always transport patients to the hospital. Inhalation of any amount of fluid can lead to delayed complications. So decompression sickness or air embolism must be treated in a recompression chamber. Always do your interventions in drought and route. And those recompression chambers can be found at your local wound care centers, or there is one on the East Coast, I think near Greenville, around that area, in Wilmington, and there's the big hyperbaric chamber at Duke. Alright, get your history, get your sample. Always look for alcohol and drug consumption. Check for your interventions. We obtain your vital signs, GCS, a full body detail en route, and remember that oxygen saturation readings may be produced a fault flow reading. Alright, and then recheck everything, and every 5 minutes in your trauma patient. Alright, provide blanket protection from the environments and needed. IV access, but do not delay transports by intending IV access. Remove the patient from the water, high flow tubing, left lateral recumbent position or head down. Look for pneumos and do pump transport. The key is to management of patients with the serious ascent problems is to recognize that emergency exists and treat as soon as possible. Submerged vehicle incidents, the safest time to escape from a submerged vehicle is immediately after it enters the water. So attempt to remove the passengers from the vehicle as quickly as possible. Pay close attention to the body temperature of a person who is rescued from the water. Treat hypothermia caused by immersion in cold water the same as hypothermia caused by cold exposure. Prevent further heat loss from contact with the ground, stretcher, or air, and transport immediately. Pump. Breath holding syncope happens when swimmers who breathe in and out rapidly and deeply before entering the water. Hyperventilation lowers the carbon dioxide level. Swimmer may not feel the need to breathe even after using all the oxygen in his or her lungs. Treatment is the same as that for drowning or submersion. So you could get injuries from boat propellers, sharp rocks, water skis, and dangerous marine life. So remove the patient from the water, protect the spine, oxygen, dressing and splints if indicated. Try to remember that a child is involved in a drowning or submersion may be the victim of child abuse. So handle according to laws regarding suspected child abuse. Alright, prevention. Appropriate precautions can be prevent from most emergent incidents. All pools should be surrounded by a fence at least 6 foot high and slats 3 inches apart or less, and self-closing and self-locking gates. The most problem cause is lack of adult supervision and devolve of public education to make people aware of hazards. Alright, high altitude. Dysbarism syndrome injuries. Signs and symptoms caused by difference between the surrounding atmospheric pressure and the total gas pressure in various tissues, fluids, and cavities of the altitude. When an unacclimated person is exposed to the diminished oxygen pressure in the air at high altitudes, affects the central nervous system and pulmonary system. Acute mountain sickness is caused by diminished oxygen pressure in the air at altitudes above 5,000 feet, results in hypoxemia, and signs and symptoms include the following. High altitude pulmonary edema occurs at altitudes of 8,000 feet or greater. Fluid accumulates in the lungs, hindering passage of oxygen into the bloodstream. And there's your following signs and symptoms. High altitude cerebral edema occurs in climbers who climb above 12,000 feet, may accompany HAPE and can quickly become life-threatening. HAPE and HAPE may overlap with the following signs and symptoms. So treatment includes providing oxygen, descent from the height, transport the patient, and CPAP may help. Lightning injuries. Approximately 35 people die from lightning strikes in the United States each year. Most death and injuries by lightning occur during the summer months when people are outdoors. Lightning strikes are a massive discharge of electricity occurs between two bodies that have different charges. So a person may not sustain a direct hit from lightning to be injured. Lightning carries enormous electrical power. Electricity from lightning is direct, not alternating. Lightning injuries tend to resemble blast injuries, So you have damages to the tympanic membranes of the ears and air containing internal organs. Muscles damage may occur and release myoglobin from injured muscles may jeopardize the kidneys. For the cardiovascular system, lightning acts as a consummate defibrillator. Someone with ganglia pulse after a lightning strike can have a respiratory arrest is known to result in a secondary cardiac arrest if left untreated. Central nervous system is almost invariably affected by lightning strike, and look for the entrance and exit one. Skin boils are usually superficial, full thickness burns are rare. Injuries are categorized into as being mild, moderate, and severe. Immediate life threats include airway obstruction, respiratory arrest, and cardiac arrest. Alright, so first priority, get the patient and rescuers in a safe place. Always take care of yourself first, so look for the possibility of some more lightning strikes. Alright, if you feel a tingling sensation or your hair stands on one area, the area around you has become charged. So curl up in a ball and squat. Make yourself as small a target as possible. Alright, a lightning strike is apt to injure more than one person. Determine the number of your patients. Reverse triage. Start CPR, and when establishing the airway, keep in mind the possibility of cervical spinal injury. Use your jaw thrust maneuver. Severe bleeding is present, control it immediately. Manually stabilize the head in this position. Restore arrest, BVM. Use an advanced airway if possible. And training. Make sure the scene is safe. Priority treatment goes to the patients who are not breathing. Get your CPR started. Establish the airway. Administer supplemental oxygen. Insert a large bore IV catheter and deliver isotonic crystal solution wide open to keep the kidneys flushed down. Cover any surface burns with dry, clean dressings and splint wrap. Alright, bites and envenomation. Spiders are numerous and widespread in the United States. The female black widow spider and brown recluse spider deliver serious life-threatening venom. So the spider may be still in the area, so your safety is paramount. Alright, just some information on the black widow spider. Alright, the bite is sometimes overlooked, becomes numb, water away. The patient may not recall being bitten. So it causes localized pain and symptoms, and the venom is neurotoxic. Other symptoms: dizziness, sweating, nausea, vomiting, rashes, tightness in the chest, severe cramps develop within 24 hours, and usually signs and subside over 48 hours. You can treat with Valium and Ativan. Clean the wound, clean the bite site with soap and water, and apply ice pack. Brown recluse, here's some information on it. The bite is not painful at the site but becomes slow within hours, and also develops over the next several days, and the bite rarely causes systemic symptoms and signs. Correction, systemic Heman, nocturia stings. They are painful but are not a medical emergency. Remove the stinger. And it's still present in the venom sac. So clean thoroughly with soap and water or a antiseptic solution. Anaphylaxis may occur, so be prepared for that. Snake bites. There's several snakes out there, but only 19 are venomous. There's a picture of each one of those. Here's some information about the snake. I believe that a snake is a dead snake, so I don't like snakes at all. Some information about pit viper. Signs of envenomation by pent viper include all of these: coral snakes, some information about. So you keep the patient calm, have the patient lie supine, develop the approximate time of the bite, and clean the bite with gently with soap and water. However, do not apply ice to snake bite. Use a perform pressure immobilization device and place the affected extremity below the level of the heart. Be alert for anaphylactic reaction. If the patient was bent on the trunk, keep him or her spine supine and quiet and transport as quickly as possible. Okay. Monitor signs and symptoms, vital signs. Mark the area with the pen. IV therapy according to local protocol. And if the snake has been killed, bring it with you or take a photo. Take a photo. If no signs of envenomation, BLS, sterile dressing, immobilize the site injury. Alright, scorpion stings, found primarily in southwestern United States. Venom may produce a severe systemic reaction, and antivenom is available. Just notify the ED as soon as possible. Tick bites, they're painful. Correction, they are not painful. The danger is from the infecting organism that tick carry. So it's most common in Lyme disease, Rocky Mountain spotted fever. The longer the tick stays embedded, the greater chance the disease will be transmitted. Rocky Mountain spotted fever occurs within 7 to 10 days after the bite. And there's some signs and symptoms of it. Lyme disease, there's your symptoms, and it's treated promptly with antibiotics. Transmission of infection from the tick to the person takes at least 12 hours. So using fine tweezers, grasp the tick by the head and pull it gently but firmly straight up. Marine animals. There's many different kinds of marine animals out there. Jellyfish, remove the patient from the water, remove the tentacles by scraping them off. Wash the affected area with vinegar. And limit further discharge from pneumatosis by avoiding fresh water. Alright, so a patient may have a systemic allergic reaction, toxins from the spines of urchins, stingrays, and certain spiny fish are heat sensitive. So the best treatment is to mobilize the affected area, soak it in hot water for 30 minutes. That's the end of this chapter. The patient with cool water or fan him or her to quickly evaporate the moisture on the skin. Get your IV access and administer crystals at 20 ml per kilogram.